I'm Matt Malone. We're going to talk a little bit about the learning environment, which has been mentioned once or twice already. So we're going to define the learning environment. We're going to describe positive and negative features and discuss a little bit about trainee mistreatment, and then talk about some ways to improve or optimize the learning environment. So what is the learning environment? So the learning environment is the structural and social context where the learner does their learning, and the learning environment also influences the behavior, emotions, and practical competencies of the learner itself. It's different than the learning climate, which is essentially how the learner perceives the learning environment. There are a lot of factors that contribute to whether the learning environment is a positive or negative. Some of these things are pretty obvious, and we think about or talk about pretty frequently. Things like your learning materials and your assessment methods. Some of these are within your control and others are not. But there's also a fair number of factors that can influence the learning environment that are both out of your control and something that you don't, may not always think about. I'll give you, for instance, if I'm in a 1 p.m. lecture and I neglect to eat and I'm hangry, I'm probably not going to be very engaged and having a good time. So how these students experience the education that you're providing them has a lot of different factors. The features of an ideal learning environment really come down to being respectful and engaging, right? You want to be welcoming and collegial and all of that. You want it to be a safe environment, and you want it to be student-oriented whenever you can, as opposed to teacher-oriented. Things that bring the learning environment down a little bit can be pretty obvious, right? Things like making students do a lot of scut work, having a culture of fear, the things that you were talking about earlier, things like profanity and humiliation, excessive workload or work hours can contribute as well. And probably the most important thing that I can think of is the feeling that the student has no power to change the learning environment. They have no mechanism for feedback to explain and demonstrate their concerns. The LCME under Standard 3 defines the learning environment kind of in 3 different ways. First, that it's professional, respectful, and intellectually stimulating, but also within their 6 substandards, there's some descriptions of the benefits of diversity and promoting attainment of competency, things like research as well. So we're going to go through these LCME standards briefly before we get into more of the fun stuff. So the first LCME standard is that your medical students at some point need to work with residents. This may or may not apply specifically to your clerkship, but at some point during their medical school training, they need to be involved with working with residents. Similarly, again, this may not apply directly to your clerkship, but they also have to have opportunities to participate in research. They don't necessarily have to participate, but they just have to have the ability and opportunity to. Similarly, again, may not necessarily be related to your clerkship, but there has to be some sort of diversity pipeline related to recruiting underrepresented minorities and providing success of the students in these categories. And then there also needs to be a written anti-discrimination policy that states that your institution doesn't discriminate based on age, race, gender identity, national origin, etc. Somebody's having a good time. So at Ohio State, we have, related to LCME 3.3, we have a MedPath program, which provides a path for underrepresented minorities to get involved in research and to get into medical school and things like that. So the next two are probably the most important for the clerkship specifically. So Standard 3.5 relates to the learning environment and professionalism, and it basically states that two things. One, that the medical school has to ensure that the environment is conducive to learning, and that professional behaviors are encouraged and unprofessional behaviors are not. But specifically, and I think the thing that's most important here, that the LCME clearly states that it is your responsibility as a clerkship director or as an administrator for your institution to track and periodically evaluate the learning environment. We're going to be talking a little bit about that and how that works. And then the last LCME standard is regarding student mistreatment. So it defines a code of conduct for faculty-student relationships and has a mechanism in place for non-compliance with this code of conduct. So you have to have some sort of reporting system and a system for identifying the problems and going through them, addressing them with the people involved, et cetera. So, as I said, the LCME indicates that you are responsible for tracking and evaluating issues with the learning environment. And there's a lot of different ways you can do it. So, probably the most common way that I've seen or heard about is having specific learning environment related questions in your end of clerkship surveys. Things like, was the faculty or healthcare team, did they create an environment that promoted professional values? Were you as a student mistreated in any way? Was the supervision appropriate for the level of the learner, and was that considered a safe environment? Were you treated with respect by your teachers? And specifically, I think there's another one that's interesting, is like, do the teachers may treat you perfectly well, but do they treat the residents like crap? That's going to be something that a learner picks up on and is something that needs to be addressed as well. This actually has, as Dr. House can attribute based on his manuscript here, it does have an effect. So if you're tracking this, it can improve the learning environment for the students and their experience and perception of it as well. All right. The other thing that's very important is to have some sort of student mistreatment reporting system. A lot of students may not necessarily feel comfortable, stating specifically that it, in a end of clerkship evaluation or an end of shift evaluation that they were mistreated, which is why it may be beneficial or important to have some sort of anonymous reporting system that's institutional wide, that is investigated by sort of an independent team and can get down to the bottom of any mistreatment scenarios. The other way that this is assessed, the learning environment of your medical school, is through the AAMC graduation survey. So there are a number of learning environment topics that are addressed in the survey. It identifies who is mistreated, who did the mistreatment, what actions were taken, etc. Here's a link to it if you have access to these slides later. And you can see, it's pretty robust as to the types of questions that are involved. Respecting diversity, showing empathy and compassion, etc. And then there are some specific questions related to physical harm, public humiliation, which I'm sure in your experience, you've all probably seen this at some point. I've heard it say, like, this is not an opportunity to air your specific grievances, right? And I think students use this as an opportunity. So when students are filling this out, you don't want them to use your one specific example from your clerkship as the reason why they, say they are occasionally publicly humiliated. All right, so we're going to talk about a few other specific types of issues related to the learning environment. So one of them is the effects of gender on student experiences. So, it's pretty well established that, well, not well established, but, there are people out there that will make assumptions based on specialty choice or perceived roles based on gender, and this can cause pretty significant discomfort to specific individuals. And this also sort of falls into the realm of unsolicited sexual attention as well, which is not something that we want to be doing. Specifically, romantic and sexual relationships between a supervisor, teacher, or some sort of power differential is a conflict of interest. It is the responsibility of the person in the position of authority to eliminate that conflict of interest, right? It doesn't necessarily mean that people at an institution that have different levels of power aren't able to have relationships, right? There are many examples of, for instance, attendings being married to residents. You just have to mitigate the specific conflict of interest so that that those people in the relationship probably shouldn't work directly together. They shouldn't be performing, the person of authority shouldn't be performing assessments of that learner, and we should minimize any potential harm we have on the person of lower institutional authority. Somewhat similarly, sexual harassment is sort of defined as any unwelcome sexual advance, request of a sexual nature, other physical or verbal conduct that is unreasonably interfering with an individual's work or academic performance. This is oftentimes addressed at the institutional level, like raise your hand in this room if you've done some sort of online module related to Title IX. It's almost, it's an institutional requirement essentially everywhere, but there are opportunities within the context of your specific learning environment, i.e. your clerkship, that these issues can come out, right? So we as emergency medicine clerkship directors are not immune to this, and we need to be aware of the processes to go through when this becomes an issue, right? So usually in your Title IX online modules, it gives you examples of how to address these issues at your specific institution. And taking the matter into your own hands is not necessarily the correct answer. However, with Title IX, there is specific reporting requirements, right? So if if you're having a conversation with a learner and there is sexual harassment involved, it's often a good idea to disclose that with your learner. Like it sounds like this is going to be a very difficult conversation. I just need you to know that anything that you tell me that is related to sexual harassment, I have a duty and a requirement to report to the institution. So outside of sexual harassment, et cetera, there are other types of mistreatment that can often go unchecked. So microaggressions are sort of subtle comments that are unintentional and often unconscious, but reinforce some sort of stereotype. Neglect is not benign, right? So some students will feel mistreated if they are not being actively engaged with by their teachers. And then the other two we've sort of already touched on is so the lack of civility between departments, professions, et cetera, or specialty bashing. Stereotypes are there, they're touchy and they can be funny, right? Everybody's seen the Dr. Glockenflecken TikTok videos, right? I literally ride my bike to work and drink nothing but Diet Coke. The guy has me pegged. But if you reach, it's fine to make fun of yourself, but if you reach out to other specialties, whenever I have somebody on, an orthopedic surgeon on my rotation, I was like, oh, my brother's an orthopedic surgeon, so he lets me make fun of them. It's still not okay. So the types of incidents that can occur in this mistreatment are, sort of as follows. Things like belittling or aggressive questioning, embarrassment and humiliation are kind of the ones that I've seen and even participated in on occasion, much to my dismay. The two at the bottom in sort of in bold and big letters are the ones that are generally hard to miss and oftentimes are the biggest deal, but it doesn't mean that necessarily that the other things aren't important as well. So a marginalized learner is anybody who sort of differs from the team or environmental norm, and this can be anything from race, gender, sexual orientation, things like what degree you have. So MDs and DOs, right? There's definitely people out there that that make that distinction and make it known, or even sort of your level of extrovertedness, right? So we as emergency medicine doctors tend to celebrate the student that is outgoing and engaged, but it doesn't necessarily mean that they're better at their job or will be a better emergency medicine doctor in the long run. It just means that their personality is one that gets energy from social interaction as opposed to having energy taken away from them. So I kind of burned through those pretty quickly. So let's spend the rest of the time talking about these cases because I think this is kind of the fun part. So case one, you are hearing a medical student present a case to the team of a male patient who is HIV positive. The resident asks the student if the patient is gay and then asks, is he a pitcher or a catcher? The student is visibly uncomfortable, says he doesn't know. There's some kidding that goes back and forth about the guessing to the answer to the question. You look over to your group of learners and how do you address this situation? Is this okay? I mean, is that language acceptable? Right, because the context is often really important, right? It is clinically important to know if somebody, you know, gives or receives penetrative sex, right? Because the clinical implications are there. Yeah. So what other ways can you have that conversation with, or what other variables may change how that interaction goes, right? So. Yeah, right. So having that conversation in a public forum is much different than pulling them aside and having it in a private conversation. Is there benefit to that public forum at all? Like, would anybody ever consider doing that? Because there might be, right? Like, it's important for everyone in the room to know that what was said is probably not appropriate, but how the person being called out may not be as receptive to your feedback in that case. You were going to say something, go ahead.
Well, we have an attending who is much older on a different service who is very well known for making inappropriate comments, and it's been years. This has been ongoing, and multiple people talk about it and everything. And I think it's at that point, if they're not willing to change, calling them out in public is probably like the next step, like a nuclear option. But if they're not willing to change, and there's been a lot of time and repeated attempts.
So yeah, we can flip this case around a little bit. What if it wasn't a resident? What if it's like your medical director or the vice chair of education who makes this, offhanded comment? You.
That changes a little bit depending on like who's making the comment. I think in this scenario, you are leading a team of people, and so there is some benefit to like stopping and saying this is an inappropriate way to talk about patients, as opposed to like if it's an offhand comment like while you're signing out, you're like a colleague, you're like, well, this isn't my team that I'm running, and I'm not sending this over to this team, but then it would be beneficial to have that conversation with them, not to give them preferential treatment for who they are, but just to say, like, you've got a resident that clearly is, not discussing patients in the way that we should hope that they would discuss patients. It's not like a minor thing, like, oh, I noticed that you kept saying non-compliant as opposed to non-adherent, or like something minor that you can have like a conversation of. You don't know why the student would be uncomfortable or like the dynamics of everybody on your team. So I think it's more important to talk about it on a group level.
So do you think, going back to, we had mentioned in previous lectures, going back to assumptions, is there utility in discussing this directly with the student that was involved to get their perspective on the situation? Yeah.
Yeah, I mean, I think this is something that I would keep with the students separately afterwards.
Sure.
Take some notes and make sure that I was following that.
I think the challenge is if we don't, it's very uncomfortable for us to address things, and I think we have to think about the challenge of how you address things, but if you don't address the, like, contributes to the culture, and then it becomes acceptable, and it probably says more to the team when you don't say something and address it than if you do say something.
Yeah.
My two biggest
on to the second case. So during sort of sit-down rounds, the attending arrives a bit early. The resident is finishing up an urgent consult. The attending gives her a Starbucks card to the medical student and asks him to get coffee for the team while they finish up co-signing notes. So nobody's doing anything engaging as a group at this point. So you decide to put the medical student to good use. I'm gonna be honest. This is something that I did kind of once on accident. Didn't even think about it. I was like, we have nothing to do right now. Anybody hungry? Why don't you go? Can you go get everybody something? I thought I was doing something nice, right?
But their response was less
Oh yeah. Their response was, my job is not to get you coffee.
right. But giving them a choice of use my money to get yourself food and coffee if you wouldn't mind, and also this for the team. Yeah, that's. I would have thought that would have been okay because you're giving them an option and you're getting them food and drink.
Yeah, so this is people think about scut work as that undesirable tasks, but in reality, what it is tasks that are unrelated to the clinical environment. So, would the context of this change if you're asking the student to do something menial and doesn't require thinking and doesn't require processing and medical knowledge and things like that, but it is related to the clinical context, right? So if you say, hey, we're all doing stuff right now, can you go track down the MRI CD of this random patient for me?
I don't think that would work. I mean, it's not pleasant work, but if nobody else was there, would I have to go in and ask yes? Then I think that's something that's pretty, if I ask a medical student to call poison control, it's not the most clinically, most teachable moment, but it's something that we do in the emergency department.
That's a skill though. Talking poison control is a skill. You have to talk. Are you talking about just reporting the patient information?
No, having the conversation with the poison control.
That's a skill.
Yeah.
You need to know how to have that engagement, and then when they have to call again in the future, it's not a foreign concept.
Sure. I think you could say the same about handing somebody a stack of 100 pages of this is their stuff from the outside hospital, civic, that's a skill too. It's not enjoyable.
So what if it's a patient that they've had no contact with? So it's a patient that that is you're on your team, but they haven't seen that patient, and is there a way to, do you get them involved as an opportunity, right? Or
If you're going to get them involved, I always try and give them something in return and reactivate for them. So if it is a patient they don't know and I need them to run the desk, I'll say, there's a lot of high acuity patients here right now. It would be really helpful for the team. If you're at a point, can you run this desk? I asked their permission, I'm not go do this thing. Are
Great.
you at a point? Can you run this desk? Okay, when the images are uploaded, let me know, and we'll talk about whatever it is. We'll talk about how to look at DWI sequences on an MRI. And so I try and
Fancy.
trade a point if they're doing something for me. But it's helpful because then they'll run it and they'll look at them when they're uploaded, let me know, and we can work together.
I love the idea of asking permission because it gives them autonomy. Do you ever foresee a medical student saying no to any request you have like that though?
They have, but it's usually from the public. Good reason. They're like, oh, well, I just talked to this other resident, and they also asked if I could go help them do this ultrasound. And I'll be like, oh, okay, that's great. I'll let the resident know, think you're gonna run this disc, and then you'll pay in 2 minutes, I can help them reprioritize, but I've never had them flat out just be like, no.
Yeah, exactly. So typically.
I like the way you talk about from a team approach too, because it's the same as your internal medicine team. We are all taking care of all of these patients in our pod department, whatever it is. So
I think there are lots of wrong answers. Like, most situations. I would say that, if you ask a student to do something completely non-clinically related because it's convenient for you, it's not something. It will be viewed upon as an infraction of the learning environment for sure. At least that's the experience that I've had. And what's so funny about it is like you don't think, you're not even thinking about it. You're like, I'm going to do something nice, right?
Yeah.
But going back to like kind of the learning environment versus the learning climate, right? Students perceive things completely differently than the way you are trying to express them sometimes, right? So coming at them and thinking to yourself, oh, I'm going to do this nice thing for all these people and buy them some coffee, and we'll give the medical student something to do with the 5 minutes that it's going to take me to do the notes that I have. It's just not necessarily, it doesn't always come off like that. All right, here's the last one. A student on a colleague's team comes to you for advice. She stumbled on a presentation the other day, and the attending said, well, I suppose that's okay for a blonde. Today, he said, after seeing a bookish patient, I bet you like nerdy guys, you probably like to dominate them. Later text her, suppose I shouldn't say everything I think. So what do you do in this situation?
Help the student follow the stream.
Yeah, they got a file that needs to be recorded.
Yeah, I would say the first thing that you have to say to that student is, whatever you're about to tell me, I'm going to have to report. Like, I think giving them, because some students may come to you and solicit advice or like ask for advice, thinking that it's going to be anonymous and they're going to be able to make their own decisions. But legally, if you hear stuff like this, it is now your responsibility to report it. So you can't, like, it's not even that they have to report it, you have to report it, right? If you are saying that this is sexual harassment or falls within the definition of sexual harassment, and it involves, especially if it involves a student, right? Mandatory reporting says that you have to be involved. Now, you can give that specific advice, right? You should say, here are the mechanisms to get this, taken care of. But once you're in, you're kind of in. At least that's my understanding. Does anybody have a different understanding of?
Mandatory reporting.
Yeah. So other than saying that this has to be reported, what other advice do you tell this person?
Confirm kind of what's going on and let them know that this is not right.
Yeah.
And then find maybe other options for them to meet the different teams and get in
Talk about some process if they feel like their grade has been impacted by this as to how you're going to address that. And then this is really an institutional problem for escalation. This isn't the first time this is going through.
But also probably make sure that I engage when you have value beyond these comments. You as a student are going to be a physician, you are intelligent, you are worthy of respect. Just kind of reaffirming that they are an independent entity beyond these comments.
Absolutely. So, how would you, if at all, would you address the problem directly with the person saying them? Would anybody actually say anything to that person?
I might notify them that they're being recorded so that they're not as blindsided, but that's about it. It's not my job to
Sure, I agree.
So I think you have to be careful about notifying them because if it's temporally related to when the student told you and you trace back to them, then it doesn't give the students the protection that they need. So, and I think this is a hard idea if it's a colleague. I mean, I think this is something you have to escalate institutionally, you have to work with the chair of the department. There needs to be an investigation of this, and so I'm not sure that I would probably let the person know directly as much as I'd probably let the process play out and look for other circumstances. But it absolutely cannot impact the student. So I think, and a lot of times even if you're going through Title IX, the student can say, I want this to be investigated, but I want to get my grade first. Or I don't want it to, I would want to hold for a month before I have this conversation with you. We talk further. So depending on how your Title IX works, there's other ways that can temporarily separate the student from that experience.
100% agree. I think any decision you make to intervene can tip off the person who was the offender into knowing who it was that is reporting them, and allow for some sort of what's the word? Not revenge. It's the other another R word. Yeah, retribution. So does anybody else have any instances where, I think you had talked about your learning environment experience. Anybody else have any ones they want to share with the group before or ones you think might have been interesting or?
Another thing is just to, I think sometimes we have our lens and we think about the belittling or the, the more sort of subversive comments that aren't in your face. And every year I'm surprised when GQ look at things, behaviors that are related about specific sexual harassment, attending to offer to write me a letter of recommendation in exchange for sexual favors, or I got punched, and things that I think really sometimes make me go, wow, I can't believe anyone at our institution would have ever done these things. So I think probably when I was a junior clerkship, I'm like, these things don't happen. What are people talking about? And then it's eye-opening sometimes.
We have like 2 minutes for one more.
So don't be dismissive, I guess, is the.
So going back to this sort of idea of physical violence, we had a really interesting scenario like a month ago, and I probably should have put it on here. But it was a student that complained because an attending asked them to go see an agitated psychotic patient. And the student says, I don't feel comfortable, I don't feel safe in that environment. And the attending says, that's your job. If you're going to do emergency medicine, you're going to have to put yourself into situations that make you uncomfortable and where you don't feel safe. It was a really interesting